So today we'll take two important bacteria, mycoplasma and ureaplasma. And as announced, enterococci, lecture enterococci, as has a portion of actinomyces as well, and bioterrorism. So these are to take home or read it on your own lectures. They are posted over there, and you can have it as a PDF, and they will be in the second half of bacteriology. Anyway, so important thing for the mycoplasma and ureaplasma is that mycoplasma are resistant to penicillin, cephalosporin, vancomycin, and other antibiotics. And these are like beta-lactam antibiotics that you are pretty much used to it. So you start thinking in terms of the moment that information is provided to you, you start thinking of cell wall. So you can see since there is no absence of cell wall, there's no point giving these antibiotics to people suffering from mycoplasma. So they, if mycoplasma causes pneumonia and you treat the patient with these antibiotics, it's not going to work because these antibiotics interfere with synthesis of cell wall, and this does not have a cell wall. It also is important in terms of the terminology that we use, that we initially were trying to figure out whether we should put that into fungi or we want to put it up into some other category. That's the word myco comes from. And also keep in mind mycoplasma pneumoniae. We're talking about many different organisms that cause pneumonia, because pneumonia is a serious problem. And you can see this typical case. Firstly, I will give you an idea. As a young adult, you should not have pneumonia. You should never have a pneumonia, because your immune system should be strong enough to fight pneumonia. Pneumonia we have usually at extreme ages, younger or older people, and very serious. But if you have pneumonia as being a young adult, then it's going to be fatal. There's something going on in your immune system that's there. One of the reasons is that we call mycoplasma pneumoniae, and in this case, a typical case that you can see is an unusual case, as I just told you. A healthy 18-year-old woman, and she sees her physician, and she comes with respiratory complaints, and look at the chest radiograph, and this is consistent with pneumonia. Because remember that young people tend to ignore, they tend to procrastinate and delay unless it's really, really emergency. So in this case, you can see that she saw her physician before she came to the hospital, and they prescribed fluoroquinolone, but there was no response. So most of the time, when the physician sees a pneumonia, immediately they will think of bacteria or viruses, and if they give antibiotic like penicillin group and it doesn't help, then there is a serious problem. Since she failed to respond, we admitted her to the hospital. She gets high fever and productive cough, and then they want to change her antibiotics to another one, which is macrolide cephalosporin. Again, nothing happening. So remember, that's a very tough decision. If you think it's a bacterial pneumonia, I'm going to pass this attendance sheet here. And condition deteriorate. She gets pulmonary infiltrates, have bilateral pleural effusions, and even goes to the liver failure. Now, the question we had in our mind was that we gave her aggressive antibiotic therapy, we put her respiratory support, and her disease progressed to hemorrhagic pneumonia, which is like blood coming out from the pneumocytes with multi-organ failure, and she dies on day 35, which is the longest in the hospital. So that's a typical presentation of an pneumonia in a young girl. So they initially thought that the diagnosis of mycoplasma pneumonia infection was based on positive serology, looked at the antibody titer, and then look at the microscopy like gram staining. They also looked at the culture and PCR. But the problem was that they could not possibly come up with a drug that is there to treat mycoplasma before it takes the life of that particular young adult. So as I said earlier, young people should not have pneumonia. If they do, there's a serious problem. We have to really vigorously treat it. And in this case can lead to a failure of antibiotics and the multi-organ failure just because of this culprit over here that happens to be a mycoplasma pneumonia. On a spin side, also keep in mind that there was a lot of biotechnological work going on, and I'll just give you an upshot related to mycoplasma. Who's doing mycoplasma as individual projects? So make sure that you also add that historical perspective because it's important. So what happened was that there is a DNA researcher by the name of Craig Venter, and he wanted to break the code for human genome. And he was thinking to himself, if by the end of the day we are all DNA, so why don't we put the DNA together and create a life? That's what his idea. So that actually would make sense in terms of to create an artificial life. And the idea was you kind of get this genome together and stitch them by hand, and that's what they did. So they picked up a bacterial genome and created that in the lab, and that of course is got published in Nature because this was the so-called creation of the first artificial organisms. But again, it's challenging as well if people start doing it. It's uncontrolled. So you can imagine we'll just add on to the pool of problems, not the pool of discoveries that we have. So why did he choose mycoplasma? That's interesting because he chose mycoplasma. This is the smallest living cell, and this could have been easy for him to stitch together. So if it's a smallest living cell, so you can put the DNA together and you should be able to kind of manipulate that. So that's what probably he claimed he did, okay? Now in real life, even this simple organism has few hundred genes, and if you were to complete the genetic code, it's gonna take at least 500,000 letter long, so more than 1,000 times than a human being. So they started up with this small bacteria and wanted to kind of synthesize by assembling those genomes and then get this 4-letter code, ACTG, put them together and create life. That was the whole idea. And you can well imagine the scientists may have weird ideas, but if you look at the whole hypothesis was they wanted to create a synthetic life. So 2002 synthetic virus was created, a lab version of polio. But again, you can tell by this maybe like a fiction, microbiology fiction thing that if they start doing it, that we may have another problem. So 2007, genome from one cell is placed in another. 2008, this is the one that we are talking about, they completed this study in terms of genetic genome study. So mycoplasma is important, and the whole idea is that they are, for those who are doing research in those areas, they picked it up because that's the smallest free living bacterium. Now, one of the mechanisms that we do for sterility, you're going to go and do lab as well. I think it's P2 somewhere, when they want you to know how to make sterile preparations, for example, like injections. And one of the things they do is that they have a small sieve which has a pore of 0.45 micrometer. So why do you think that you should have to have a pore size of 0.4 micrometer to purify and make this injection sterile. Why 0.45 micrometer? That again?
Because of the bacteria size?
Very good. Exactly. Very good. Because of the bacteria size. If the size of the bacteria is more than that and you have a pore smaller than that, all bacteria will be filtered. That's what we do. Very good. Now, the other important thing is that this particular bacteria can pass through 0.45 micrometer. Then we have a problem. So this means once you have any injection or any liquid preparation, so you want to, next time you see that on injectables, when you open up injectables and you give an injection, you will see a sign over there, mycoplasma tested or mycoplasma free. The reason is because it is less than 0.5 micrometer. That makes sense? So that's important. The other important thing is that it doesn't have a cell wall, and the cell membrane it has contains sterols. So remember, when most of the bacteria would not have that. So this particular bacteria contains sterol. It also has a slow rate of growth, generation 6 hours, strict aerobe. What does that signify? If I say very strict aerobe, what does it signify? Okay, so what does it signify? That's what the word means. What does it signify? Why do we need to know that? Speak up. What I just gave you a story of this young girl having what? Pneumonia. So it's an aerobe is going to cause pneumonia because it wants to stay in the lungs to get oxygen there. As compared to anaerobes, which are going to go for intestine or dead tissue. So there's a good reason for us to know that it's an aerobe. It has one of the important things, it is called P1 adhesion protein, which basically binds to cilia and epithelial cell, and it will kill the epithelial cell. So that's the most important thing, especially for attachment. Again, a virulence factor that you can see that is out there. It stimulates inflammatory cell release of cytokines, is a strict human pathogens. There are nice videos you can watch at your own time. But if you want to look at the structure for that, especially the clinically structure of mycoplasma, we basically study 3 different types of mycoplasma. Number 1 is the one mycoplasma that causes pneumonia. Number 2 is the one that is a normal vaginal flora. It's called hominis. And the third one is mycoplasma genitalium, as the word suggests. That's the location of this particular bacteria. Now, the most important, of course, is the one causing pneumonia. And the very special thing about this pneumonia is called atypical pneumonia. So if the moment you hear about atypical pneumonia, start thinking of mycoplasma because it's atypical, especially with the case that the young girl, she didn't feel anything. Normally when you have pneumonia, especially in the babies, it's a very serious thing. So they will have respiratory distress. Why do we need to know about mycoplasma hominis? Because if it's a normal vaginal flora, and many a time, especially post-vaginal delivery, mothers may get post-abortal fever. So that's another, or after abortion or normal delivery, because of the trauma caused to the vaginal canal during childbirth. There always are chances that the normal flora may find an opportunity to go invade and cause problem. So very common cause for post-abortal fever among all these 3. Okay, and again, genitalium is that there as a part of male and female genitalia. Size of mycoplasma, I'm kind of over and over stressing to you, is the 0.5 micrometer. So this can pass through normal sieves that we normally use for sterilization. And this was a challenge, as I said earlier, and this again happens to be one of the most important slides that you should expect quite a few questions from there, because you want to compare. Initially, there was challenge whether we want to call mycoplasma a bacteria or not. So that's where it began the problem. We wanted to put it into some category, and we were trying to make sure that it classified, because microbiology would take care of all microbes. So you kind of sometimes take one and put it in the other, right? So in this case, let's say one of the characteristics was growth outside the host cell, right? So you have to have a host cell to grow, okay? If that's the case. Now, in this case, what happens is that normally bacteria can grow outside the host. So if you can put a bacteria on this table, it's going to grow. But if you put a virus on the table, would it grow? It would not, because that's a parasite. And by the same nature, rickettsia, chlamydia, which I'll have one lecture on, does need a host factor to grow like viruses. So you can see from here that it took us time to take this away from viruses because of the other reason. And if you want to place like bacteria to the left, virus in the right, and which way is going to go, or put them something in the middle. So we ended up putting these things in the middle and more towards bacteria. So you can see mycoplasma is more towards the bacteria because it shares that characteristics. Independent protein synthesis, yes, it has independent protein synthesis. Viruses do not have independent protein synthesis. They're going to take your protein synthesis. Generation of metabolic energy, of course, they can, but viruses cannot. Have a cell envelope, very rigid kind of a cell envelope. Well, yes. For bacteria, you should have, but I just told you that penicillin is not active on there, so it does not have that. So that's like sticking point over here. That's different. If I was to ask you what exactly are the characteristics that differentiate from a typical mycoplasma being a part of bacteria, so that's one of these important things. Okay, so you can see if you were to compare that with bacteria, pretty much the same. You can see from here, pretty much the same. This is the only difference. So protein, what do you call the cell wall. Now at the same time, I will discuss all these separately, but at that time I would say, okay, go back and look at that lecture that compares rickettsia, for example, or chlamydia with viruses. So you can see this was the challenge that we have in terms of classification of these microorganisms, either to the left or the right. Okay. And one of the important things I'll discuss in detail is chlamydia, which is where we have elementary bodies or reticulate bodies, very specific for chlamydia trachomatis. Does anybody remember what did it tell you about the chlamydia trachomatis? And it was a part of gonorrhea. Say it again? Say it again? Louder. Very good. Correct. This was the #1 STD in the world and in this country. That's what I told you. STD, chlamydia trachomatis, a prototype STD, sexual transmissible diseases. So that again is going to be taught separately, chlamydia. Did you do today's exam or you're just coming fresh?
I just did
okay.
Okay.
All right. All right. Okay. You seem to be the only person who's answering, so maybe I don't want to. Okay, there you go. Culture, if you were to culture, again, a very common question asked for mycoplasma. If you were to culture them, one will appear as fried egg, the other will be mulberry, So this is hominous as compared to pneumonia. Mycoplasma hominous would compare to mycoplasma pneumonia. And other unique structures that we've been talking about, that there are some other terms that we use, especially in chemistry, you talk about these L forms, we talk about L forms and D isomers. So what we do in this case is, apart from whatever we discussed before, that cell wall deficient bacteria are called L forms. They normally do not have sterols, but this does have sterols. So that's an important thing, right? And the rest of the information is pretty much the same. The only thing that you have to make sure is that when the size is very small, and remember when talk of size, it's going to be like length and breadth. So the pore size will determine, as I said, the normal pore size for sterile injection is 0.5. So bacteria are larger than that, but bacteria can be placed in a different position to pass through that. So if it goes by the breadth, it can easily pass as compared to the length, because length is going to obstruct that. So the other important thing that you can see in the chart, that we initially were thinking that maybe it's a virus. So that's why we had this struggle. We were initially thinking that they are viruses, but then no, we tend to kind of put them a little bit towards bacteria, and the only difference was the cell wall synthesis. For their division, typically, like all bacteria, they grow by binary fission, divided into two mother, divided two daughter cells. Can grow on artificial cell media. They contain RNA or DNA. And though they are aerobes, but they can be facultative anaerobic, especially except the pneumonia, because pneumonia has to be a strict aerobe, because that causes infection over there in the lung, right? And then again, if you were to look at the generation time, you can see a slope. And the other important thing for this particular group for mycoplasma is that since they don't have a cell wall, so we then have to look at their cell membrane, which basically have glycolipids and protein. And that's where the problem is, because sterol will also antigen will cross-react with human tissues, because most of the bacteria have cell walls, so whatever responses you get should not cross-react, other than some of the, what was the most important bacteria that I told you normally cross-reacts with human tissue? What was the bacterial antigen or name of the bacteria so far that we have discussed cross-reacts with human tissues? Group A, streptococci. Remember we talked about rheumatic fever. I said that you want to check person if he has sore throat because of cross-reactivity, rheumatic disease, because the cross-reactivity of the. So, this is another important aspect for mycoplasma, that it can cross-react. Now, as far as pathogenesis is concerned, I'm going to spend a little bit of more time on adhesive proteins, especially P1 adhesin, that is there, and that is going to interact especially with the receptor at the base of epithelial cell cilia. So they are ciliated, like hair-like projections on the respiratory epithelial surface. But at the same time, they may have similarity on the surface of erythrocytes, so they have the common kind of receptor. Now, what normally happens is that, for example, I told you in the chronic smokers, the ciliated epithelium gets messed up, so you cannot push out or expectorate out the mucous secretions. Now, if that kind of activity is lost, right, because of that bacteria being stuck to that base of the hair, we call that a stasis. The typical word is ciliostasis. Right, so ciliostasis. So there's no pushing forward movement as happened in chronic smokers. So this is going to stay over there, and then again will cause problems, especially persistent cough or the smoker's cough kind of thing that we normally see. But the pathogenesis is attachment via P1 adhesion. So that's important for that. Now, if you look carefully over here, again, this is a typical epithelial cell. And the epithelial cell basically will have a cilium, the hair-like projections, okay? And what happens for this bacteria is that this will come and attach over here. So there's space in between. So if there is a denudation of, if this denuded is, kind of free of this space, this bacteria will come and attach over here. And you can see from here, it has got the receptor, will attach to the receptor over here, especially P1 adhesion receptor, you can see from here. And then it will go and cause problems. So this is the adhesion molecule that we normally see, especially for P1 attachment and the pathogenesis of this particular bacteria. Other than that, it produces cold heme agglutinins in immunology, which are IgM antibodies, and they also react with, as I said, one of the cross reactation is with the class 1 antigen on human RBC. Why do RBCs have class 1 antigen? Okay, I'm not going to ask you, you already are tired, that's fine. So 2/3 of the patients that we normally see are there in terms of when you get infected, one of the tests that we commonly do is check for IgM levels. That's what we do. And that again is important in terms of the term that you use in clinically when you're asked what is cold heme agglutinins, cold heme agglutinins. So we would mean mycoplasma pneumonia initiated cold immunities as compared to any other responses that we normally see. Now, the other important thing for that pneumonia is that they act like a super antigen and release typically Th1 type of response. And then again, this response is required to eliminate the process. So the same thing, if it's uncontrolled or if it is not properly regulated, it is beneficial to get rid of bacteria, but at the same time, it's going to cause damage as well. Epidemiology is present all over the world with no seasonal incidence. And then again, primarily infect children 5 to 15 years, but all population are susceptible. Again, it's a droplet infection, so people are going to cough up or throw up in sneezing or coughing this particular bacteria. Okay, and of all other statistics that you will see, I would want you to pay attention to the cases that we normally see in the United States. So we do see about like 2 million cases. So you can imagine this out there, pneumonia, 2 million cases. And they all need hospitalization, and they all have pneumonia. However, as of today, I believe it is not a reportable disease, and the tests are not available. So if the tests are not available, of course, the true incidence is not known. And again, it's also called atypical pneumonia. The other name for that is that we call it walking pneumonia. So you may have pneumonia and you are okay, you're just walking with it. Right? And there's no test available. So these are some of the things that we normally have to keep in mind in terms of epidemiology. The only other close contestant for causing pneumonia, of course, Streptococcus pneumoniae. Streptococcus pneumoniae. So I just looked at one of the questions and I asked for the spelling for Staphylococci. And if there are 80 students, I've got 80 new names, spellings of Staphylococci. There's going to be, in my dictionary, of 18 different ways to spell Staphylococci. All right. Acute pharyngitis is very common. As I said, it's called atypical pneumonia or walking pneumonia because people may not find the typical findings. And then again, people normally, like sickness, you have myalgias. And since it has cross-reactivity, so that's where most of the questions will come. If a pneumonia presents with neurological symptoms. Like, for example, it has meningoencephalitis, paralysis or myelitis, right? So these are the secondary complication of mycoplasma pneumonia because of the cross-reactivity. Because it doesn't have a cell wall, it has cell membrane, so sterol and glycolipids may have a response which is pretty much the same for the other one. It can also have some other organs involved like heart, joints, and then skin. That's the general immune response that you normally see. Okay, now clinical picture, as you can see, if you were to put a week post-infection, of course you get infected, you would not know, right? And maybe after 2 weeks of infection, then you will have a typical malaise-like feeling, like I'm unwell, I'm sick, that kind of feeling that you have. And then in the later part of that, you may present with pneumonia. So once you have pneumonia, that's where you're going to go to the hospital and they're going to do 2 tests. So these are the common asked questions. One is a serum antibody complement fixation test, and the other one is cold agglutinin titer. I just gave you this mean IgM. So these are elevated. But if you come later, then you may not have these 2, as a diagnostic test. So those diagnostic tests are only when you have pneumonia, right? But if you want to test them in terms of culture, you can culture bacteria in the sputum in the later part of the clinical picture that you normally see in terms of pneumonia. As I said earlier, mycoplasma pneumonia may cause diseases like an upper respiratory tract or lower respiratory tract. The other important thing that we normally teach along with mycoplasma is another bacteria we call ureaplasma. So there are 2 different ones, right? And the urea, as the name suggests, is something to do with urine, something to do with the urinary system. Keep that in mind, but again, is a plasma kind of thing that has the same similarity. So ureaplasma, especially urealyticum, also invades genital urinary tract and then will cause a typical disease, which is urethritis. And then again, it's going to be passed out in urine, okay? So don't confuse that with mycoplasma hominis. That was normal vaginal flora as compared to another ureaplasma, which is urealyticum, in terms of causing genital urinary tract infections. Okay, so let's put them together in terms of comparison, in terms of sites. If you were to see them, and I'm pretty sure that these tables are very useful from the book, and this is where we need to find out differential diagnosis. Now, mycoplasma pneumonia, genitalium, hominis, compared with ureaplasma. So you can see from here, 1, 2, and 3, they can invade respiratory tract, right? But mycoplasma genitalium, as the name suggests, would only invade genital urinary tract, whereas mycoplasma hominis and ureaplasma can invade both. You can invade basically respiratory tract as well as genital urinary tract. If you look at the typical diseases, it can cause upper respiratory tract, lower respiratory tract infection with neurological symptoms. When it comes to mycoplasma genitalium, this was one of the causes when you were asked, what are the causes? This is all the questions I'm going to ask you, especially for part of gonorrhea. What are the non-gonococcal causes of urethritis? What it suggests to you is urethritis basically is caused by gonococci. Most of the time, people will only come to you when they have drips, they're passing blood or pus in urine. That's what's called urethritis. And you will test them for STDs. But at the same time, you have to rule out some of the bacteria. One of the bacteria you want to rule out is, of course, mycoplasma genitalium, which is called NGU, non-gonococcal urethritis, a term very commonly used in STD clinics. Okay? We talked about mycoplasma hominis. I already discussed that. And then again, ureaplasma ureticum is also a cause of non-NGU, which is non-gonococcal urethritis. Okay, and again, as I said earlier, for mycoplasma hominis being a normal vaginal flora, at the same time, ureaplasma also is very common. Has a very common prevalence when people have spontaneous abortion or premature birth. So these are some of the things that you really want to look at and make sure, because the idea is that if you see these patients, gynecological patients who have had abortion or post-abortal fever, you cannot possibly give them antibiotics alone, especially beta-lactam antibiotics, because that would not solve the problem. They may have some other things to take care of. Okay, now if you look at the tests that are available, again, test is not useful. Why is it not useful? Because there's no cell wall. If there's no cell wall, what are you going to stain? Simple. Okay, you can culture, but the culture is slow. It takes a lot of time. So you want to go for molecular diagnosis, rapid diagnosis, right? Like PCR based. Or you want to go for serology, which means immunological tests. Like I just told you, complement fixation, ELISA, and the most important is cold agglutinin. And these are some of the important things that you want to do in terms of diagnosing a patient. So the best drugs that are available to take care of these are fluoroquinolones. They are important. And then again, erythromycin, doxycyclines can also be given. Immunity to reinfection is there, but it's not lifelong. And we are still struggling to find vaccines because they have proved ineffective. Why have vaccines proved ineffective for mycoplasma and ureaplasma? Yeah, because there are no cell wall antigens to make our antibodies against. So if you give antigen from the cell membrane, then you end up causing more damage. Because the vaccine's antibody is going to pick up your own tissues and cause neurological complications. So they've been pretty much ineffective. And this is a good YouTube that you can copy and paste and play. But again, the problem I figured out for the YouTube videos is that most of them are old and obsolete and doesn't go well with the textbook information. So textbooks are usually more advanced as compared to, but if you want to go for the basic concept, you can always do that. Okay. Again, as I said yesterday, probably, that your online literature and online site has some of the key points listed for a particular bacteria. So they are very good resources. So they are going to give you on a single page, what is it that you need to know about this particular bacteria, and you can recap or kind of review that. So for those of you who have not purchased the book or are not interested in buying the book, can help themselves from these slides. Okay, one more review case, as you can see, because as I said earlier, all you need to do is that you want to go back and remind yourself of a particular case and then go and work up your information from there. So this is how best you can learn. So in this case, again, a case study for review, sometimes, especially for, as I said, online book version, gives you a case in the beginning. So it kind of goes into your mind. By the end of the day, all this information is meant to treat patients. All this information is not meant just to know and forget. It has to be there in your mind at all times before you look at that. Now, in this case, again, increased lethargy. So this is more of a malaise feeling. Headache, cough, low-grade fever, and then chills and sweat in a young person, right? And she goes to the certain health center, and they see that there's a fever. That's why you have a high pulse rate. respiratory, what's the normal respiratory rate?
12 to 20.
So, but, well, it varies. Yeah, it varies, but I will take that. But it is definitely 28, higher than what should be. Look at the pharynx. Erythematous, he has rhonchi, not rales. I'm not going to ask you what are the difference between rhonchi and rales. I'm sure you know that. But there's a consolidation on auscultation. They go for a chest radiograph. They look for the patchy infiltrates. They go for the gram staining, and they couldn't find anything. Gram staining revealed sputum. You know, sometimes somebody was asking me this question today in the exam as well. What is it that you want me to identify? So there are the sputum slide, and it shows the typical sputum cell, and they are bacteria. So probably I was thinking in my mind said you just got confused by looking at the sputum cell. Do you have nuclei there? They cannot be gram staining as compared to the odd-looking bacilli they are there. So when you do a typical slides, look at them, either they are coming from swabs or secretions, so they may carry some of the epithelial cells, which should not be confused with the gram staining. But again, you can see over here, many white blood cells. What does white blood cells suggest in sputum? Are they normally present in white blood cells in the sputum?
No.
What is infection? Yeah, of course, infection. Very good. So you can see no organism. Then they look for the antibody titer, and they go for complement fixation tests, and there they find that these are the classical tests for mycoplasma. So you can see from here, this is how, what they call, we work up a patient from the presentation, from the clinical picture, because a physician has to understand the problem before it's going to go for a test. If I was to write, okay, look for the cold agglutinins, so immediately the person at lab knows that his provisional diagnosis is mycoplasma infection. Why should he send for such an expensive test? Okay, so these are some important things that are to be done before we place people for different tests. Okay, and then again, she was put on erythromycin, and it responded slowly. It took 2 weeks to recover. So this whole scene will tell you a pathogenesis of mycoplasmatic pneumonia in the age group, younger group. You know, what are the clinicals you notice for? What are the tests you go for? And the moment you look at these questions, you know, you just have to pick up a keyword, then you know the rest of the story. So there's always a catchwords in a particular case scenario that you can just pick it up, and no need for me to even talk about that. If even I was to take this blank and just put as a distractor, right, I would want you to know whether it's a mycobacteria, mycoplasma, streptococci. But if you know all this information, you have no hesitation of just putting mycoplasma there. So this is one of the ways that these difficult concepts are learned. Okay, now, as I said earlier, ideally cultures are important, but again, the problem with the cultures is that you don't want to wait that long for the cultures to come back because they have a slow growing time. And then again, when you look at this clinical picture, person showing in the hospital with patchy infiltrates of pneumonia, you would rather spend money on going on the complement fixation test. What would the complement fixation tell you? Talk about complement, right? What exactly, if you are there in medical rounds and they say, hey, we're going to go for complement fixation test, and you say, what is that? Can somebody help me to answer the question? What is a complement fixation test? All right, I'll let you go because of the exam. All right, okay, I'll stop here and take some